Good morning, everybody. I'm Howard Chansky, the chair of the Department of Orthopedic Surgery and Sports Medicine, and welcome to our April Grand Rounds. This morning, we are going to have one of our R4s, Emily Hunt, who is going to be doing a spine fellowship, and Karina Katchko, who's an assistant professor in the department, and her specialty is spine surgery with a particular focus on minimally invasive spine surgery. And the title of their talk is Evolving Technology in Spine Surgery and the Radiology Trade-Off. And I just want to remind everybody to get your CME credits in now, because after, I think, an hour after Grand Rounds ends, it becomes a little more challenging to do that. So thank you, Dr. Hunt and Dr. Katchko. So just tell everybody they can either put something in the chat box or text me. Questions.
For questions at the end, you can either text Dr. Chansky or Aaron or put it in the Zoom chat box. Good morning, everyone. Thank you for being here. Today, Dr. Katchko and I will be talking about evolving technology in spine surgery and the radiation trade-offs. I have no disclosures. There are a few key takeaways that I hope you leave with today. First, we'll look at how spine surgery has evolved and how that shapes the way we operate today. We'll talk about the radiation trade-offs that come with each advance in technology, from open surgery to minimally invasive to navigation and robotics. We'll discuss the occupational risk it creates, especially for spine surgeons and women entering into the field. And finally, we'll look at where the technology is headed and how we can better balance patient outcomes with surgeon safety. Before we get into that, I just want to talk about the motivation for today's talk. During my spine fellowship interviews the past few months, something that stood out to me was the wide range of techniques that surgeons use to accomplish very similar surgical goals. In a conversation with one of my mentors, they suggested I consider learning navigation early in my career because of the occupational risk associated with radiation exposure in spine surgery, particularly as a woman going into this field. That comment has stayed with me, and when I looked into the data, I found this statistic. A spine surgeon can perform approximately 880 fluoroscopy-guided cases versus 10,000 navigation-guided cases before reaching their annual radiation dose limits. That's more than a tenfold difference and became the motivation for today's talk. If you ask most spine surgeons what the advances in our field have been over the last several decades, many would point to fluoroscopic guidance, minimally invasive surgery, and more recently, navigation and robotics. These technologies have not only improved patient outcomes, but they've introduced a trade-off we don't often talk about, which is the radiation exposure. This study, published in 2011, showed that minimally invasive surgery with fluoroscopy for a lumbar microdiscectomy results in 10 to 22 times higher radiation exposure compared to the open approach. So the same technologies that benefit patients may increase risk to the surgeon. Spine surgeons experience some of the highest occupational radiation exposure in orthopedics, just behind trauma surgeons and lower extremity deformity surgeons. And importantly, this exposure accumulates over the course of a career. To understand why the trade-off exists and why surgeons are exposed to so much, we'll briefly step back and look at the history of spine surgery. Throughout much of the 19th century, before X-ray was developed, treatment of spinal injuries was extremely limited. Spinal injuries were often treated with prolonged bed rest and often an extension to reduce pressure on the cord, with mortality approaching 70%. In 1895, Victor Horsley presented results of the first cervical spine laminectomies, which were performed for trauma and tuberculosis. All 7 patients recovered, which was a remarkable achievement in and of itself, especially considering he had no imaging. Around that same time, others began to recognize disc pathology as a cause of acute neurological symptoms. And in 1895, William Röntgen discovered X-rays, allowing us to visualize bone for the first time. This image is the first X-ray ever taken, and it's of his wife's hand. Early X-ray technology was extremely crude. It often required prolonged exposures up to 90 minutes and much higher radiation levels, up to 1,500 times what we use today. The risks were recognized almost immediately, with skin burns, hair loss, and eventually cancer in early pioneers. As imaging evolved, so did our ability to stabilize the spine. Lumbar spine fusion was first described by Hibbs in 1911 for treatment of a patient with tuberculosis osteomyelitis and later for scoliosis. For these early fusions to succeed, patients often required prolonged bed rest or mobilization with braces or body casts. The limitation prompted the development of internal fixation devices, and in the 1950s, C-arm was developed, and in the 60s and 70s, the pedicle screw plate system was introduced, allowing surgeons to achieve rigid fixation and eliminate the need for prolonged immobilization. These techniques that require direct visualization of the spinal anatomy, reinforcing the need for wide surgical exposures. Historically, and still today, large exposures are necessary for three reasons. First, we need direct visualization of the anatomy. Second, we rely on anatomical landmarks for safe placement of instrumentation. And third, achieving biomechanical stability often requires broad access to the spine. While advances in imaging have allowed us to minimize exposure in many cases, conventional open approaches are still necessary in many situations, such as complex trauma, deformity correction, corpectomy procedures, and revision surgeries. But extensive exposures do come at a cost, with muscle injury, multifidus detachment, and wide surgical corridors lead to atrophy and fatty degeneration, which are correlated with postoperative pain. This study by Few compared paraspinal muscle degeneration between conventional open surgery and minimally invasive transforaminal lumbar interbody fusion, or TLIF, and they found that open surgery was associated with significantly greater fatty infiltration of the erector spinae muscle, nearly double compared to MIS, 27 versus 14%. They also saw a trend toward greater multifidus degeneration within open surgery, and these findings were part of the rationale that ultimately led to the development of minimally invasive techniques in order to reduce the degree of soft tissue injury. So what is MIS? Minimally invasive spine surgery aims to achieve similar outcomes to open conventional surgery while minimizing the soft tissue injury from the surgical approach. It encompasses a wide range of techniques, including smaller incisions, tubular retractors, and percutaneous instrumentation. And it relies on technologies such as fluoroscopy, navigation, and robotics. These imaging technologies are essential because they compensate for the loss of direct visualization that occurs with these smaller approaches. MIS techniques are now widely used for degenerative conditions, some deformity, and trauma. But importantly, open surgery is still essential in many situations, such as for severe deformity, requiring pedicle subtraction osteotomy, vertebral column resection, trauma, including fracture dislocations, and block tumor resection and complex revisions. MIS techniques are not a replacement, but rather an expansion of our toolbox. MIS focuses on preserving muscle attachments, avoiding muscle crush injury from retractors, like what is shown on the left, and minimizing the corridor width. In this large multi-center matched study comparing MIS versus open TLIF, MIS was associated with less blood loss, reduced opioid use, and shorter length of stay following surgery. There was higher patient satisfaction at 3 months and similar five-year fusion rates. By 12 months, the outcomes were similar to open surgery with a lower reoperation rate. So MIS clearly has advantages, but it does require a different way of operating. Without direct visualization, localization, and instrumentation such as pedicle screw placement introduced a new dependency on intraoperative imaging. In the early 2000s, percutaneous pedicle screws were developed to support minimally invasive techniques. Without direct visualization of the anatomy, surgeons began to rely heavily on biplanar fluoroscopy to guide screw placement. This highlights the difference between open and percutaneous pedicle screws. On the left, you have a traditional open approach with full exposure of the spine, where you have direct visualization of the anatomy and can place instrumentation under direct vision. Whereas on the right is a minimally invasive approach where the visualization is replaced by small percutaneous access points. Achieving accuracy requires repeated fluoroscopic imaging, with one study showing that it takes about 5 to 6 AP X-ray shots per screw. So while MIS preserved muscle and improved patient recovery, it also introduced a new dependency on intraoperative imaging. This is where the trade-off emerges for the patient and the surgeon. When open surgery uses fluoroscopy sparingly, mainly for localization at the start of the case and for confirmation of implants at the conclusion, MIS relies on it continuously, and as a result, radiation exposure to the surgeon, OR staff, and the patient increases. This was one of the first prospective studies to directly compare radiation exposure for the same procedure for a lumbar microdiscectomy performed using an open versus minimally invasive technique. The authors found a 10 to 22 times higher increase in surgeon radiation exposure with the minimally invasive approach. Importantly, while exposure increased across all regions of the body, the largest difference was seen in the hands and the chest. Hand exposure was over 20 times higher, and chest exposure was about 15 times higher compared to open surgery. And that makes sense because during fluoroscopy-guided MIS, the surgeon's hands are closest to the beam, and the chest is directly in the field of scatter radiation. This has become a foundational study in the spine literature, highlighting the occupational trade-off between MIS and open surgery. And it's the increased radiation exposure and the inherent risks that come with it that's driven the development of newer technologies like navigation and robotics over the last 2 decades. Radiation exposure is an occupational hazard, one that we're all aware of, especially being in this field and using it on a daily basis. Spine surgeons, trauma, and lower extremity deformity surgeons receive among the highest levels in orthopedics. Radiation exposure has been associated with a number of occupational risks, including cataracts, thyroid cancer, and breast cancer among female orthopedic surgeons. There's also evidence suggesting an increased risk of melanoma in radiation-exposed healthcare workers, and emerging data recently has linked chronic radiation exposure to cardiovascular disease. Importantly, these risks accumulate over the course of our career. And because a significant portion of that scatter radiation occurs at the chest level, and breast tissue is among the most radiosensitive in the body, that raises an important question about whether this exposure affects all surgeons equally. When we look at the workforce, women represent only about 4% of orthopedic spine surgeons in the United States, making it one of the least gender diverse subspecialties. This paper, published in 2024, highlights that. There are many reasons for the underrepresentation, but occupational hazards and specifically breast cancer risk may be one factor that deserves more attention. The first study in 2012 showed about a 3-fold higher prevalence of breast cancer in female orthopedic surgeons compared to the US population. This has increased to nearly 4-fold in more recent data. The authors also compared orthopedic surgeons to other surgical specialties like plastic surgery and urology that does not rely as heavily on fluoroscopy, and found that this association between breast cancer and radiation exposure did not exist, suggesting that the occupational radiation exposure is what is associated with breast cancer. More broadly, meta-analyses have demonstrated this breast cancer relationship, in addition to higher rates of infertility and pregnancy complications, which is multifactorial. So why is this happening? One explanation is a protection gap. So the upper outer quadrant of the breast, which is called the tail of Spence, is breast tissue that extends up into the axilla, and it receives much higher doses of radiation compared to the lower quadrant. It's the most common site of breast cancer, and standard lead aprons don't adequately protect this area because armholes leave that tissue and the axilla exposed, which can be made worse by poor fit. For cross-table lateral C-arm projections, which are commonly used in spine surgery for verifying placement of pedicle screw, depth, and trajectory, and assessing sagittal alignment, produce the highest scatter radiation. In this study, it compared different positions of the surgeon relative to the C-arm, and it showed that lateral views resulted in about a 7-fold increase in radiation dose compared to an AP image. When the surgeon is facing the table, as shown on the left breast receives the highest exposure, whereas when you're turned 90 degrees to the table, the right breast receives the highest exposure. Several studies have looked at ways to improve breast radiation exposure beyond the lead vests that we all wear. They show that adding lead sleeves and axillary supplements can reduce radiation exposure to the upper outer quadrant by about 96%. In contrast, axillary wings, which are shown in this image, which many of us in this residency have added to our lead, provide less protection, and in some studies were not significantly different from a standard lead vest alone. So the key takeaway is that the wings alone are not sufficient for optimal breast protection, and more comprehensive protection like sleeves or axillary supplements are needed. These images showed 2 different solutions: axillary supplements, which are essentially axillary wings that are moved down and attached to the existing apron to cover the lateral breast and axilla. These are other options for axillary protection beyond the wings. There's also lead sleeves that provide circumferential upper arm coverage and understandably protect you about 96% relative to a standard lead vest or a lead vest with wings. So finally, we'll dive into how navigation, robotics, and evolving technology in spine surgery offer a solution to the radiation problem. It's important to recognize that navigation wasn't originally developed to reduce radiation. The primary goals were to improve accuracy of instrumentation placement, enhance patient safety, and reduce surgical morbidity. Radiation reduction has really been a secondary and somewhat under-recognized benefit of navigation, but it may be one of the most important benefits when we think about surgeon health and career longevity. This is a prospective study that compared fluoroscopy and navigation during lumbosacral fusion. The most striking finding is the difference in the cumulative radiation exposure. A surgeon could perform up to 883 cases per year with fluoroscopy guided and reach their annual radiation dose limit, whereas with navigation, that number increases to 10,000 as we previously discussed. It's more than a tenfold difference. And then when you look at the right hand exposure specifically, the right hand with fluoroscopy experiences about 560 microsieverts of radiation exposure compared to roughly 50 with navigation. So again, a tenfold difference. Navigation changes when the radiation occurs and where the surgeon is when that happens. So with conventional fluoroscopy, the surgeon's standing at the table, shooting the C-arm repeatedly throughout the case. Every time you check a needle, a wire, a screw, you're exposed to scatter. With CT-based navigation, there's a one-time radiation dose limit that's upfront, and it's in a single acquisition at the start of the case. During that scan, the surgeon and the OR staff can leave the operating room or can stand behind shielding to protect themselves. And then once that navigation system is registered, the instrumentation phase is essentially radiation-free. So you're placing screws in real time with tracking and not using repeated imaging. With fluoroscopy in MIS cases, you receive radiation every time you place a screw, whereas with navigation, each screw is essentially zero radiation. While navigation dramatically reduces the radiation exposure to the surgeon and the OR staff, it's important to recognize that this benefit comes with a trade-off. With intraoperative CT-based systems, patient radiation exposure increases by roughly threefold in some studies. So although we're reducing exposure to the surgeon and the OR staff, we're shifting that exposure to the patient. So this becomes an important consideration, particularly in the context of informed consent and shared decision-making when consenting the patient for surgery. Robotics represents another image-guided option, similar to navigation, but with an important difference in how that guidance is delivered. With navigation, we rely on visual feedback on a screen, and the surgeon translates this information through hand-eye coordination. Robotics builds on that by adding mechanical guidance, where a robotic arm, like shown in these images, helps direct instruments along a pre-planned trajectory, rather than relying on the surgeon's manual alignment. Emerging technologies aim to reduce radiation further. We have there are ultra-low dose CT protocols that maintain image quality with less radiation. There's emerging technologies such as photon counting CT, which represents a fundamental advance in detector technology. And then there's MRI-based synthetic CT, which could eliminate radiation entirely from the preoperative planning. All these are aimed at reducing radiation while maintaining improved surgical accuracy. So to summarize, conventional open spine surgery relies on wide exposure and direct visualization. Minimally invasive techniques improve patient outcomes, but come with the increased reliance on imaging throughout the case and ultimately higher radiation exposure to the surgeon on the order of 10 to 22 times compared to open techniques. As a result, spine surgeons experience some of the highest occupational radiation exposure in orthopedic surgery. And this risk may not be evenly distributed, as female surgeons face a disproportionate risk, particularly with respect to breast cancer. Navigation significantly reduces radiation exposure to the surgeon, and robotics may represent the next step for their optimizing radiation exposure while adding mechanical guidance. So as spine surgery continues to evolve, I think we should think not only about how we operate, but how we protect ourselves while doing so.
All right. So I think Emily has done a good job of presenting a lot of the data that's kind of helped guide us or help us with decision making. I'm going to talk a little bit more about sort of what I've been doing in my practice. I don't have any disclosures that are relevant to this talk or any at all, I guess. So on my kind of personal journey going through radiation. So in the beginning in medical school, I feel like this is maybe not an uncommon experience. There's not always enough lead. You're looking for random lead in the operating room. You have to hide behind your residents or the nearest staff, and thyroid shields in particular were frequently missing. And then in residency, so not all residency programs provide funds for lead, which I kind of feel that should be something that's standard for an orthopedic residency since it is an occupational hazard. But so for myself, I was able to use a grant that I was supposed to originally go travel to a meeting with. And then they said I could reuse the funds because all the meetings got canceled in COVID. And I used it to buy my own lead. And this is when I was a PGY5. Prior to that, lead that was available can often be ill-fitting. I would tape myself in because it usually was like huge, at least at our hospital. And again, thyroid shields are pretty frequently missing. I did also purchase like leaded glasses on my own, and then I purchased loupes on my own. So not all cases you can use leaded glasses for because you may need the enhanced visualization that comes with loupes. But it was something, those are things I accumulated over the course of 5 years in my residency. So I do think it's a good thing that you guys all have the option to purchase your own lead that's better fitting, because that was something that my co-residents and I all kind of had to, we're always kind of scrounging around to keep ourselves protected to the best of our ability. So in the present day, I do have lead that's fitted. I haven't purchased these like axillary covers, which is now something I'm thinking maybe I should add. And for percutaneous cases, I'll often use leaded glasses. And then I have 2 different pairs of loupes depending on what I'm doing. So we'll talk a little bit about the eye protection. So what are some of the things that I'm worried about in the operating room with my radiation exposure, like cancer? I think Dr. Hunt talked about that nicely already. There's the risk of cataracts with repeated radiation exposure to the eyes, fertility, the patient, but also the rest of the team, because even though, I'm getting probably the most radiation exposure because I'm going to be the closest to the C-arm in many instances, your staff, like your scrubs and your circulators, anesthesia, they can all be at risk of increased exposure as well. I think in particular, you take a shot if like somebody's, you say your CRNA is turned and the lead is just a front-facing apron, all of a sudden they're getting a dose of radiation if they're not kind of aware or directed in the right direction. So the cancer risk, again, this was already pretty nicely discussed. I think something that I'm going to be looking into is getting something that provides enhanced axillary coverage, just because it's like, well, I don't want breast cancer because of my job, which I think probably most of us don't. So in terms of cataracts, there's a paper done in Australia. A lot of this research seems to be done in Australia, but they did a study that was quite straightforward. They took loupes, leads, and plastic face shields. They put a dosimeter in front and then a dosimeter behind, and then they tracked how many shots it took to reach like the same amount of exposure. And they were able to find that loupes decreased radiation by about 97%, even if they weren't leaded, and leaded glasses decreased the amount of radiation by almost 100%. While this isn't a perfect paper because you're often not directly facing the beam of radiation and blocking the radiation directly, you're getting scatter or radiation at an angle, maybe from the side of your face, but it's at least nice to know, since I do wear loupes quite frequently, that at least I'm getting some sort of eye protection from those. And I kind of talked about that. I did, of note, I did try leaded loupes once, and they were so heavy that I started getting pressure sores on my nose. So I did abandon those because I was not excited about that. So fertility, there's a higher rate of infertility amongst surgeons and orthopedic surgeons. Female surgeons have about a 32% rate of infertility compared to the general population, which is around 11%. This is a multifactorial issue. So example, many people delay family planning, and you can't change things like maternal age, but there's other occupational exposures, including radiation, but also PMMA, bovie smoke, but those are kind of beyond the scope of this talk and things that were. So in terms of fertility, they did find that the amount of pregnancy exposure you can have, intrauterine exposure a fetus can have, they calculated the dose of how many cases they felt you could safely do before you reach that number. These doses were calculated, estimating that somebody was wearing 0.25 millimeters of lead, which is sort of a standard lead amount. And the number that I kind of want to highlight is for lumbar spine surgery for a fusion with 4 pedicle screws. The fetal dose, you could do 23 procedures before you reach the max pregnancy dose that you're supposed to be having a fetus get intrauterine, which is pretty low. I was kind of surprised by that number. And this is, again, only taking into account 4 pedicle screws, didn't really take into account any inner body work. And I think especially being at an academic center doing some more, maybe you're doing a fracture or a more complicated case, but you're going to be doing a lot more than 4 pedicle screws per case. I did look back at what the lead that I purchased was, or that I currently am using. The protection is kind of gradated. I have 0.5 millimeters of lead in the front and 0.25 millimeters in the back. So that may give me a bit of wiggle room or the ability to do a few more cases. But still, I think 23 cases over the course of 9 or 10 months or whatever it is it's not a ton of cases before you're really have to start thinking about whether it's safe. So I guess, next steps would be making sure to just continue decreasing personal exposure, adding distance between myself and the C-arm when I do take fluoro shots. Again, continue to use some other technologies to help limit my own personal exposure in the future. And I think the team is really important too. There is a trickle-down effect. If I decrease my personal exposure, that can help decrease everybody in the room's exposure. I have to imagine that our surgical scrubs are getting a lot of radiation just like we are. And I think it's also nice because after the spin is done for registration of any type of navigation, a lot of times that gives people the opportunity to not wear lead, which is people are more comfortable, less crabby when they're not wearing, their leaded gowns and getting so hot the whole case. So advanced imaging modalities, I'll talk a little bit about the workflow that I generally do, and this is applicable whether I'm doing, we have 2 options for navigation, or I guess now 3, but there's the more traditional navigation where you're going to be using just navigated instruments, as well as the robot where you add the robotic arm or the trocar arm. So for registration array placement, generally, this is something that I do without any x-ray. I'll palpate the iliac crest and I'll use like a 6 or 4 inch, depending on how big the patient is, their spinal needle to palpate their iliac crest. And then I can make a percutaneous incision to place that registration array. For the CT registration, I should say spin, not spine, I'll leave the room for this. So then the staff gets the option to step out of the room as well while the highest radiation is going on. Fluoro, I do generally still take at least 1 AP and 1 lateral image to confirm screw positioning after hardware is placed. And again, after a rod has been passed for percutaneous cases, because you want to make sure, God forbid you miss feeding it through one of your screw tabs or something like that. But I think it's better to just do a little bit of double checking. So this is obviously, if I'm taking, I guess the minimum is still going to be about 4 fluoroscopy shots, but that's a lot fewer than, the estimated, 5 to 6 per percutaneous pedicle screw like Dr. Hunt presented. There we go. So advanced imaging modalities. So in terms of selecting cases, there's also time versus benefit considerations. So for single level posterolateral fusions, the amount of time that it takes to place registration arrays, get a spin, do those screws, there's probably not going to be a lot of benefit in terms of time. For single level cases, you're probably going to be slower if you need to do that whole process of obtaining a CT scan in the beginning. microdiscectomies. I was a little surprised to see that the amount of radiation was so much higher for microdiscs that were done percutaneously versus kind of more traditional and open, because I do feel I take relatively few shots of fluoro for that. But I guess now I better keep better track. Advanced imaging can add time to a case, or it may just be a break even. So when selecting cases, there are some cases that I do have a strong preference for using navigation. I think in particular, when we do lumbo-pelvic fixation after trauma has already done some sort of SI joint fixation, there's a lot of screw traffic. It just decreases, I would say, frustration time trying to work your way between corridors. In patients who are very obese, or for X-ray may just be more difficult to visualize their anatomy altogether. Patients with abnormal anatomy, so dysplastic pedicles or previous surgeries with a lack of landmarks, it may be a good reason to bring in the advanced imaging modality. Or super small pedicles. A good example of this is on trauma call, had a 12-year-old with a fracture with translation. Her BMI was about 50 and her pedicles were all between 2 and 3 millimeters. So it's like, there's a lot of, not very much wiggle room, and there's a lot of tissue, making visualization challenging. So those are kind of cases where I'm probably going to almost always recruit some form of navigation, just because of safety of instrumentation placement, in addition to some of the radiation safety benefits. So some of us are more excited about using new technologies than others. And I can kind of talk about how my practice is evolving, because I mostly learned how to do posterior open surgery when I was a fellow. But things have changed a lot over the last few years. And I think almost all of us have begun using robotics and navigation as part of our practice. So as I've started moving towards doing more minimally invasive spine surgery, I do have an increased reliance on imaging for instrumentation. The tools that we have available, we do have the O-arm and Stealth available at, I believe, HMC and Montlake. And then the Globus robot is at Harborview and at Montlake. And then the new Globus navigation console is it's being onboarded at UW Northwest right now. So there's options at each of the sites that we, or at least that I go to. I'm not sure what's available at the VA or at Children's, but I'll talk about a few cases now. So first case, this is a 54-year-old female. She fell from a few feet of scaffolding, unclear how many feet that was. She had a L1 incomplete burst fracture, something that could potentially be treated non-operatively, but on her initial upright x-rays that we got, she collapsed into quite a bit of kyphosis. She did also have a potential previous compression fracture, or chronic compression fracture in her thoracic spine, which was suggestive of poor bone quality. And so she underwent a T11 to L3 percutaneous fixation. And this was done with fluoro and then using the C-armor to minimize how many bonnets were opening. This is her preoperative imaging, her CT scan, and then her initial set of upright x-rays. And then this is an example of her intraoperative fluoroscopy shot and then a postoperative x-ray. She's about 3 months post-op at this time, overall doing just fine. She's healed nicely so far and started physical therapy. And for an example, the radiation from the fluoro in this case, there's 146 seconds used on C-arm fluoro, which was a dose of 61, milligray. In comparison, this is not quite an apples to apples case. This case is an 87-year-old female with a history of ankylosing spondylitis. She had a T8 extension type 3 column fracture, who underwent a T6 to 10 posterior spine instrumentation. This is something that I did with the robot. You can see here on her CT scan in the midline where that sort of transverse fracture line is, as well as how it's traveling through the both sides. This is what her post-op imaging looks like. She's also about 3 months out. She has dementia, but she's overall doing well. She's able to ambulate and has started doing some therapies as well. So my C-arm time for her was about 46 seconds as compared to 146 seconds. Because again, I do always check with fluoro after implants are placed to make sure that I've safely placed implants where I think I have. And this was about 10 milligray of exposure on the C arm as compared to, what was it, like 61? So it's a pretty big decrease in how much, as I think that this fluoro exposure time is essentially a proxy for my fluoroscopy exposure during the case. There were 21 seconds of the CT registration spin, which added 116 milligray for the patient's exposure. But again, we anticipate this is a one-time dose for the patient, or we hope that everything goes well and is a one-time dose for the patient. So big decrease for me, moderate increase in the exposure of radiation for the patient. So kind of what am I looking to do in the future? Looking into starting to navigate interbody fusions. There's also an option for posterolateral fusions to navigate drills and do facet decortication, and then you slide like a funnel down over it and you can put bone graft in there. So you're still doing fusions and not just decortications, but also expanding into doing larger types of cases with a more minimally invasive approach and using navigation to help me do those things. This is an example of an upcoming case. This is a 75-year-old male. He was previously walking marathons and doing multi-day hiking trips where he's walking up to 35 or 36 miles in a day. He started canceling his trips about a year ago because he had back pain slowing him down, and he does have some right lower extremity radicular pain. In the past, he's already done extensive physical therapy. He's had epidural steroid injections, and he has a remote history of an L4, L5 microdiscectomy. These are what his standing x-rays look like. He has about 8 centimeters of positive sagittal balance of his posture. And he has his pelvic incidence measures around 48 degrees, and his lumbar lordosis is actually in about 1 degree of kyphosis. So in somebody like this, where your goals are going to be mostly deformity correction and they just have radicular symptoms, for example, in this patient's MRI, you can kind of see where he has the foraminal stenosis along this. So my arrow show up kind of, this is a L4-5 and an L3-4. And he doesn't have really any central canal stenosis. Does he really need to have a big open exposure? Because often when we do deformity surgery, it'll be a big exposure. Doing T-lifts will involve some sort of either hemilaminectomy or laminectomy for access. So what does he really need? We got a CT scan, which would show that he doesn't have, his disc spaces are fused, they're open and available for use in this instance. So again, what does he really need? He needs improvement of his posture and his sagittal alignment. And his goals are to have decreased back pain and improve his right lower extremity pain. And this is somebody where I think those goals don't necessarily have to be carried out with a traditional open surgery. Traditional open surgery, we'd be looking at an A-lift, use of T-lifts, with a T10 to ilium posterior fusion. This is most likely be open, and sometimes these are even staged depending on how long anterior access takes, blood loss, and the stress on the patient's system. And while he is like a relatively fit and healthy 78-year-old, he is still a 78-year-old, and this is a big physiological event for somebody like him. So what is my plan? I'll still be doing A-lift with a general surgeon for access, doing an L4 to S1 A-lift, doing L2 to L4 lateral interbody fusions, and then doing a T10 to ilium instrumentation with navigation, and then doing percutaneous facet decortication. Obviously, I haven't done this case, but this is kind of an example of like how I'm trying to use this technology going forward. And, you know, with using my interbodies from the A-lift and the lateral interbody fusions to help with alignment restoration. This also offers indirect decompression of the foramen. And again, in somebody who doesn't have a lot of central stenosis, doing something posteriorly where you do a laminectomy and take down all that bone, not necessarily going to give him a benefit, but it does add to the overall morbidity of the procedure for him. So we'll see how it goes. Maybe it'll be a smashing success. Maybe it'll be challenging either way, because anytime you try something new, it can be a challenge. But this is kind of the direction I'm trying to help move things towards, because I do think that there's enhanced recovery when you do things with less soft tissue disruption. So I think the most important thing is that technology offers choices. All tools are user dependent. So for example, I double check all trajectories with the robot with a ball tip probe, because if you're off, you should be able to feel if you have a soft spot. And then you can figure out if you need to either transition or do it old school, bring the fluoro back in if you need to, or if there's something else that can be adjusted. I do also always use the C-arm to confirm screw position, because even if everything feels good, you better make sure that those screws are in the right place before you move on to the next step of placing your rods and changing alignment or reducing a fracture. The enhanced recovery that comes with minimally invasive surgery is, I think, something that's really a benefit to patients, and just trying to protect both myself and my team from radiation exposure while doing these cases is a priority as I move forward. Oh. Okay. Sorry, I think that's it. So we'll give some time for questions now. No pressure. I see the chat.
Well, I have a couple of questions. So is there any software where you're planning for cases and you can get estimates of what the radiation does to the surgeon that patient will be, depending on levels, what kind of surgery is going in, like that, so you can get a feel for it as you're planning the surgery?
That's a good question. I don't know if there's software that estimates radiation exposure. There are various programs where you can do surgical planning but that's is generally more focused on alignment. If you use this implant, what's your correction going to be, that sort of thing. But that would be something interesting to take a look at. It may have to be based somewhat on your own averages or, kind of general averages. Yeah. No, that's interesting.
I just have one comment about the way we protect those space. How review it. Because we use side loading system of space that's to be perfect. We use a lot of our dots. That's really not the case if you are using an ANSYS system or you go to other institutions. They probably just we can develop one final peak and the approach for most patients for deformities. Do you repeat that?
Sure. So Dr. Joe was noting that because we use a side-loading screw system, that we do end up using more fluoro per screw to place these. And at other institutions, they may just be placing screws freehand and doing a fluoro check at the end, or just doing maybe fewer fluoro shots per screw.
There's not a lack.
So Dr. Lack in the chat noted that he does observe dramatic variation in radiation safety behavior in the residents, some not wearing upper body lead, as an example. So he says good to try to lower the effects of exposure further, but also make sure you're covering the basics and covering yourself. That's probably something that there's variation on amongst attendings too. I see some people, some of them, I feel like most of I don't think I've ever seen any of the female faculty do this, but I will see like the males wear like the apron on the lower half and a thyroid shield, or a skirt and a thyroid shield only. So just something to consider.
I may have missed it. Is there data on the risk of exposure to the patient from, single extensive spine surgery with this sort of exposure, for just the surgeons?
I did more look on the surgeon end. Did you see something on patient end for exposure?
There is, I didn't go too much into it, but there is some data in pediatric patients for scoliosis. Yeah. And I know that's something Dr. Bauer will often reference, is just like when you're using navigation, pediatric AAS, or any scoliosis case, that there is an increased risk to the patient, given how young they are, with a one-time dose of the CT, that they'll likely end up having much more radiation throughout their life. So
yeah, this is Jen Bauer. There's some very good data in one paper quotes that essentially 1 in 1,000 kids, when you use navigation, will have cancer. Like that's the rate of lifetime risk. So if you do 100 scoliosis patients a year, after 10 years, you will have given one child cancer. There's a lot of good work being done right now, though, to use something called bone MRI, which takes an MRI and turns it into a synthetic CT, and work around using that for navigation. I think in general, it's our practice to avoid navigation at children's as much as possible for the risk to the child.
So that would be one additional case of cancer, because obviously many more than
Yeah.
1,000 years.
Right. Yes. Yeah. You would have directly caused it from your use of radiation on the surgery.
Yeah, and I think that I haven't seen a lot of good adult literature showing if there's a lifetime increased risk for adult patients. I think people care about the kids and the radiation exposure a lot more, so it's probably getting a bit more focused, but that's probably an area for future study.
First of all, that was really interesting stuff. So thank you. It's sometimes interesting to have adjacent talks.
Yes.
Just this line of adjacent talk. But I would also say that if any of the residents feel like their lead or their lead eye protection is inadequate for whatever reason they don't have it, just let me know, because be sure we rectify that.
Yeah. Nice. I think it's good to have a good fitting lead from the get-go, because that was, again, not having my own personal lead until I was a 5. I was like, oh man, it's a lot of years of hoping for the best with borrowed lead. So
Yeah, it's interesting. I don't think the people we work with realize how much we're exposed over the course of our careers. I just think how it's our best to work with the ED to make sure they got adequate lead down here.
yeah. And I have to say, in the operating room, probably some of the people who are the most casual about radiation safety are our x-ray techs. They're always like, oh, whatever, it's fine. I'm like, I think they just, they're exposed to it all the time and don't feel the effects of it. And so they're maybe not the role models in the operating room.
What's the data out there for radiation exposure regarding mini-seal? I mean, a lot of mini-seal.
I didn't explore mini C-arm very much because that's just not something that we utilize as much. But I think that I mean, certainly it's a lower dose per shot, but you may have your hands in the field in addition and be getting more direct exposure if you're actually, holding something or manipulating in the field. So while there is probably data, it's not something that we collected in preparation for this.
Like this.
Oh,
You may unmute.
Yeah, sorry, I was just going to add one thing. I think the concern I have about the variation behavior is exactly what you mentioned, that there's a difference in behavior, particularly between male and female residents. So I just would say I can't speak to what faculty should do. That's their own choice. And residents will, their behavior will also be under their control and they're not in OR with me. I would just ask that the male residents who think they don't need to wear upper body lead, think about the organs they have in their body that are also exposed to radiation. And it's not really, to me, it doesn't make any logical sense that you vary your behavior between men and women. There are differences in radiation risk, but they're both present for men and women. And I have a close friend of mine who passed away from a mediastinal sarcoma, who never wore chest lead. And I don't know if it was caused by that, but just a personal anecdote that was pretty horrifying.
yeah. And I mean, I think we all see variations of like attending examples. Like I had an attending in residency, I believe he had lymphoma and thyroid cancer, and he just never wore lead because he didn't want to. Like even after having cancer twice that were potentially due to radiation exposure, and the fact that he wasn't wearing lead, but he was like, I don't know, kind of an interesting approach. He was like, I made it twice, third time's the charm. I don't know. So yeah, your role models for surgery may not be your best radiation safety role models.
Thank you.
All right. Thanks, everyone.